Go ahead. Yeah. Good evening. It's a pleasure to meet all of you this evening. And we're going to discuss something about the placenta, just the basic aspects of how we use ultrasound in imaging the placenta during pregnancy. Placenta, of course, is one organ. If you start looking at it deeply, it's quite interesting to note there are several changes, and many times the changes do not seem to be commensurate with what is happening to the baby, and we need a bit more of understanding on what these changes actually mean and what is the significance in each particular pregnancy. It's also ignored many times because we usually say placenta previa or no placenta previa, and after that we don't bother too much about looking at minor details about the placenta. It's also incompletely understood in the fact that we actually look at the placenta in terms of whether the placenta is functioning well or not by actually looking at the baby size. If the baby is growing well, then we know enough nutrition is coming through the placenta to the baby. But when there is a placental problem, we rely on Doppler to tell us about the abnormalities or some problems that's happening in the placenta. It's needless to say that for this lecture, I am not going to cover about the Doppler. Rather, I'm going to look at the morphology of the placenta, location, size, and other things. If you look at the placenta as a whole, we need to know something about embryology and about the size of the placenta, looking at shape and shape problem, location, some parenchymal changes, and also some placental function. As I said, we will leave out placental function because placental function essentially is looking at Doppler, and that would become a very great lecture by itself on its own. Let's look at embryology and anatomy. The characteristics of the placenta vary with the site of implantation of the embryo. Say if the embryo is implanted very low, also there is a failure of implantation, or there is a failure of pregnancy. Very early in pregnancy, some changes occur, and we are just barely able to take out the chorionic ring, as you say, as a bright white structure. Now, in the placenta, we have three layers. One is called the decidua basalis, where the anchoring of the chorionic villi, which forms part of the placenta. So the decidua basalis literally forms part of the placenta because these villi are going to invade into that and form a one unit. The second aspect of it is the decidua parietalis, where the endometrium lining is the endometrium lining the remainder of the uterus. So the basalis is the one which is going to anchor the placenta. The parietalis is the one which is going to line the remainder of the uterus, and the decidua capsularis, where it's a thin layer of endometrium surrounding the embryo. So these are the three things which you're going to look for. But as you grow along, you'll find that the fusion with the uterine wall occurs completely by about 20 weeks. So if you see about 11, 12 weeks, there will be an amnion which is separate. The chorion is separate. By about 20 weeks, all the sputus and a complete fusion with the uterine wall occurs by about 20 weeks or so. Now, when you look at the definitive placenta, we have to think of two things. One is that the maternal portion, which is actually the decidua I talked about, where you can see the maternal portion will be close to the uterine wall, and the fetal portion, which is actually the chorion. So if you look at the chorion, you go in greater detail. The essential part of the chorion is the chorionic villi, and here the chorionic villi are the primary stem villi, the secondary stem villi, and the tertiary stem villi. This is a typical picture of a tertiary stem villus, and these tertiary stem villus shows vessels, both artery and vein, and these tertiary villus arteries are the ones which are deciding how your Doppler waveform will be. The umbilical artery Doppler waveform is decided by the resistance offered by these villi. As long as these villi are open, more number of villi are formed as the placenta grows in size, so the net resistance of the placenta keeps going down. Whereas when the villi, some of the villi are occluded, as in pregnancy with hypertension, we find that the resistance of the villi goes up and umbilical artery after abnormality are evident. Now, around the 4th or 5th month, incomplete septae are developed on the maternal side, and these incomplete septae, here you can see a placental septum here, and you can see the white area there, and these incomplete septae gives rise to the development of cotyledons of the placenta. So literally, that's why you can consider the placenta made up of multiple cotyledons, and these cotyledons are evident as the gestational age grows bigger and bigger. Very early placenta to be very smooth. If you look at the 20-week or 24-week placenta, the cotyledons start evolving, and towards term you can see individual cotyledons quite well. But as far as ultrasound is concerned, we make out those individual cotyledons only when you see lot of calcifications, and these septae are generally can very rarely be seen with ultrasound. But essentially, what we need to do is these cotyledons have an artery and a vein supply. So there will be an arterial supply, there will be a vein supply, and the cotyledons perfuse through that. And in a twin pregnancy, especially in a monochromatic twin, you can have sharing of cotyledons between the two twins. So the artery of one twin will come into a cotyledon which will be drained by the vein of the other twin, and that's typically the arteriovenous anastomosis in a monochromatic placenta. So cotyledons are important from that viewpoint. Now the placenta is a multifaceted organ, and it does a lot of things for the baby. It's the respiratory unit, it's the excretory unit, it's the digestive unit. It also does synthesis and regulation of hormones, and you can see there could be an obligatory fetal-maternal exchange of precursors from the mother to the placenta to the fetal adrenal gland. So a lot of adrenal regulation and hormonal regulation takes place through the placenta. So it's an extremely important organ, and the moment, of course, the baby is delivered, the placenta is completely forgotten. We look at the placenta from its appearance and size, the location. We look at lucencies in the placenta, and also look at other lesions. The normal placenta, when you look at it from various aspects, let's say term placenta, it's about 1/6 of the fetal size. It consists of about 20 lobes. The thickness of the placenta increases with gestation age, and it's easy to understand. If you take a direct perpendicular view of the placenta, you measure from the chorionic plate to the basal layer, the maximum placental thickness will be equal to the age, gestation age in millimeters. So if it's a 30-week placenta, which is expected to be around 30 millimeters. If it's a 20-week placenta, it's expected to be around 20 millimeters. Of course, as with all other biomedical measurements, there will be some differences at the age, which is there. But even for eyeballing, you should be able to make out a large placenta and a small placenta. Now we always apply the rule of 3 as we guess, and in the placenta, the rule of 3 is you look at the chorionic plate, you look at the placental substance, and also you look at the retroplacental space. These are 3 things we need to look at. And here a better look at these 3 areas. You can see the chorionic plate in very early placenta is very smooth. As it comes to the second trimester, there are some undulations here. There will be some breakages in the plate, which is quite normal. And then the placental substance is usually homogeneous and echogenic, and the retroplacental space is an anechoic space because it consists of the retroplacental plexus of veins. Now, identifying the retroplacental space is absolutely important in every pregnancy, especially in pregnancies where previous cesarean section or multiple DMCs have been done. The absence of this retroplacental space will tell us that this could possibly be an adherent placenta, and then we look at placenta, accreta, inflata, so on and so forth. So the presence of this retroplacental space is very reassuring that we could actually exclude an adherent placenta. Now the placental size, as we say, increases with age. You can see a 9 to 10 week placenta very smooth, and a 16-week placenta where you can see the chorionic is undulating, and it's a term placenta where you can see these calcifications. And if you typically look at these calcifications, they are around each cotyledon. This forms one cotyledon, this forms another cotyledon. and these are quite normal and part of placental aging process. And here again you can see a mid-trimester placenta and a term placenta where you can see multiple corticals are calcified. Now retroplacental space is well imaged in a lateral placenta, but sometimes you may not see the retroplacental space well in an anterior, strictly anterior placenta. That's because of the reverberation artifacts which come there and completely are through the retroplacental space. So while we were talking about adherent placenta and the identification of the retroplacental space, you have to take care that this retroplacental space in an anterior placenta, you have to image it at an angle so that you will be able to see it well. If you're having a perpendicular angle to the ultrasound beam, then this space may look complicated than actually it is not. Now placental grading has been proposed by Granum, grade 0, 1, 2, 3, where grade 0 is completely smooth. Then you have the chorionic plate and then the calcifications in the placental substance, and you have complete intense calcifications in there. But it was originally assigned to identify a maturity of the baby, lung maturity of the baby. But today we know that the grading does not correlate with the lung maturity. You can have a term placenta which is not calcified. The baby can be lungs can be mature, and you can have an early calcification, the hypermature placenta, where the baby is having growth restriction. So calcification of the placenta essentially for us is worrisome where it occurs very early in pregnancy. Let's say the late second trimester if you have calcification. Usually calcification is seen in the third trimester. If you start seeing calcification in the second trimester, we need to raise our eyebrows to see when the baby will have growth restriction. And here is a dysmature placenta in a case of autoimmune hemolytic anemia. She is only about 23-24 weeks, and you can see the placenta is already calcified. So obviously this baby is in trouble. Whereas if the same thing is seen at 36 weeks, we'll say it's part of a normal aging process. So something happening when at a gestation stage that it is not supposed to happen is what you need to be worried about. Now we have seen placental size. When you look at placental size, we can divide placentas into large placentas and small placentas. When the placental size is small, we could look for chromosomal abnormalities, intrinsic placental disorders, maternal complications like PIH and the diabetes. Diabetes can have a large placenta and also a small placenta, especially pre-gestational diabetes with pregnancy-induced hypertension, for example, could have a small placenta. Early calcification actually means accelerated maturity, and this placenta could actually look small. Now, occasionally what can happen is you can have a very small looking placenta where the area of implantation is very small, but actually the placental size will be thicker rather than thinner. But one of the reasons why the placenta is small, as you can see here, this placenta looks very thin. She's 25 weeks and the placenta is hardly 1.5 centimeters of thickness. This is because of polyhydramnios. And remember, when you let out the polyhydramnios, this placenta will become normal size because it's a soft organ. Increased uterine intrauterine pressure can cause a thinning of the placenta. It's not an abnormally thin placenta, but rather the physical effect of polyhydramnios. Now here there is the lighter is almost absent, so there is no intrauterine pressure, but you can see the placenta is very thin. Obviously, there is placental insufficiency here. Now, when you look at placentomegaly, we can divide large placentas into two groups. One of them is homogeneous placenta, and the other is a heterogeneous placenta. So, in a homogeneous placenta, you can see it in diabetes mellitus, anemia, hydrops, infection, and also aneuploidy. Whereas heterogeneous placenta is seen in molar pregnancy, triploidy, placental hemorrhage, or some other conditions where you get a heterogeneous placenta. Now, here is a very large placenta, and here you can see it's not only large, it's echogenic, and almost giving you what's called a ground glass appearance, and that's very typical of RHI mutation. And here is another echogenic placenta with gestational diabetes. Now you can hardly make out the difference between these two. Both are large and both are echogenic. Here is another placenta which is Here the 16-week fetus, you can see hardly any lighter, but the fetus is almost crushed here inside the uterus, completely crowded, and a very large placenta. So you can have a very small baby and a large placenta. Certainly means something wrong, and you need to do a karyotype for the patient. So whenever there is a gross disparity in the size, now in gestational diabetes you will have a large baby. A large baby and a large placenta go well together. Here you can see RH isomerization, you can have splenomegaly, the abdominal circumference may be large, and the placenta is also large. But here the triploidy, where the baby will have IUGR, very early onset symmetric IUGR, but the placenta will be large in size. So that's when you raise your eyebrows and say, maybe we should investigate further. Right. Now, here's a diabetes, that could be placentomegaly. There will also be villus edema and immature acceleration with fibroid necrosis. So we have to be very careful, because in patients with diabetes with a large placenta, late onset adverse outcome of the fetus can occur. So sudden IUDs can occur. So you have to be very careful about it, and that happens because there could be fibroid necrosis in the placenta late. Now here are two placentae, which one of the important things we look for in the placenta is not only the whole placenta as such, but where the umbilical cord is attached. The site of attachment to the umbilical cord is quite imperative in all pregnancies. Here is the baby with the umbilical cord which is attached almost to the membrane, and we call it as the membranous insertion. It is very close to the edge of the placenta, we call it as the Velamentous insertion. This becomes important not only in singleton pregnancies, but also in twin pregnancies, especially monoclonal twins, where a Velamentous insertion of the cord of one twin will result in poor placental territory sharing of that twin, resulting in growth restrictions. So a Velamentous insertion of the cord which always prompt one to look for a growth restriction, especially in twin pregnancies. This is supposed to occur because of trophotropism, where placental growth towards the area of petrovascularity and ectasia of the opposite side. So here you can see a classical Velamentous insertion of the cord. Now when you look at abnormal placental shape, one thing that comes to our mind is circumvallate placenta. The ability of ultrasound to diagnose circumvallate placenta is quite poor. More than 50% of circumvallate placenta will be diagnosed only after delivery, and this occurs because the chorionic plate and the basal layer are growing differentially, and because of that the edges of the placenta get rolled up, as you can see a rolled up edge, and it forms almost like a sheet or a shelf or a band, as you can see. These are very typical circumvallate placenta, which can there's supposed to be an increased risk of miscarriage, or increased risk of abruption, which could happen with the circumvallate placenta. Now, SUCCENTURIATE lobe is something which we should be very worried about, because the incidence is only 3%. It occurs because of a failure of atrophy of chorion leve on one side. See, normally when the chorion forms, you have the chorion which gets attached to the residua, and the opposite side you have chorion leve. Over a period of time, this chorion leve actually is supposed to atrophy, and if there's a failure of atrophy, that actually gives us a lobe there. It's a lobe which is separate from the main placenta, as you can see here. You do it both in the sagittal and transverse section. You can see one placenta here and another placenta here. It's only a single baby. So a single baby with two placentae, well, you need to find out where the umbilical cord is attached, and usually the opposite side is called as the SUCCENTURIATE lobe. And you can see when this happens, most often the umbilical cord will get attached to the edge of the regular lobe. So a marginal insertion can be identified there in most cases, and umbilical cord is usually attached to the main placenta, or you can say the cord attachment decides which is the main placenta and which is the SUCCENTURIATE lobe. That's the easier thing to remember. Then we start looking at placental lucencies, where you have placental lakes, intervillous thrombosis, perivillous thrombosis, septal cysts, and also subchorionic fibrin deposition. Let's first look at placental lakes. The incidence of placental lakes is about 18% to 20% of uncomplicated pregnancies. Etiologically, they are actually cystic spaces in the placenta, and they are supposed to be at the early stage of intervillous thrombosis or perivillous fibrin deposition. Here, if it's an active lake, for example, in V mode, you will actually see blood swirling. If you switch on color, you can see color filling up there. So these lakes can actually look very large. They can be single or multiple, and the lakes are supposed to be quite harmless because they don't have any adverse, or even if the lakes are looking large, generally there's not much of adverse outcome as far as that. So we don't need to worry about it. In fact, if you see placental lucencies that you see flow inside, you should be quite happy that these are only placental lakes and we can give them a sign. Now, subchorionic fibrin deposition is seen about 20% of the placenta you see. It's quite a large number, where there's pooling of blood in the subchorionic spaces. When the bleeds are very, very large and very early, for example, at 16 weeks, if you have a very large subchorionic bleed, it may artificially appear the placenta is very thick in size. And one way of looking at it will be to, in real time, is to allow the patient to move from one side to the other, make the patient move from the supine to the left lateral position, and watch in real time. You will see particles of blood moving inside. So that tells you this is subchorionic fibrin deposition or subchorionic hemorrhage, and you could mistake it for infarcts, where using ultrasound and color flow, you probably could try to decipher. And also it could be mistaken for partial mode or typhoid. So here is a classical example of subchorionic fibrin. The basic difference between this and metal and lakes is that there are no blood flow inside. There is no blood flow in these cystic spaces, whereas in metal lakes there will be constant blood flow. Here is a very large subchorionic fibrin deposition here, and if you actually make the placental thickness from here to here, it will look abnormally large, whereas the true placenta is only from here to here. The functioning unit is only here. All this is hemorrhage. If you switch on color, you will see absence of flow in these areas. In metal lakes, you will see presence of flow. In this, you will see absence of flow. And here's the patient. You can see advanced maternal age. You can see growth restrictions, the subchorionic fibrin deposition. This karyotype of the baby was quite normal, and of course, he expelled the fetus very quickly because the baby the placental insufficiency was extraordinarily significant, and the baby could continue. Now, there's a paper which came out in 2003 about prognostic factors associated with antenatal subchorionic echolucency, and they concluded in the paper that patients with subchorionic echolucencies appear to have high incidence of preterm deliveries. Bleeding appears to be a reliable prognostic indicator. So, if you have a patient which have a large subchorionic hemorrhage and the patient is also bleeding, then the adverse outcome is much more significant. Sometimes you can see a marginal hematoma. You can see the whole placenta here, and the chorion is actually lifted off here, and there is a subchorionic bleed. Marginal hematomas, most of them will regress, and especially if these marginal hematomas are close to the cervix, as you can see here, this patient will constantly complain of brownish discharge because it's old blood which is collected, and they may come, but generally most of them will regress, and really nothing will happen. Now, here is a patient who had an intrauterine demise, and when we looked at the placenta was large, and there was a lot of fibrin deposition, and on histopathology they demonstrated intervillous fibrin and villus sclerosis, which was the primary problem for the baby. So here, even at the on D1, you can see the placenta is looking quite abnormal. Right. Next, we will consider a condition called intervillous thrombosis. Now, intervillous thrombosis can be seen in 50% of term placentae. So obviously, if it's happening in 50% of term placentae, is not something you need to get terribly worried about, because you can't have 50% of abnormal babies delivering or adverse outcomes happening. It occurs in uncomplicated pregnancies. Basically, there will be intraplacental agents of hemorrhage, anechoic or hypoechoic, or it will be an intraplacental lesion extending into the subchorionic space or near the chorionic plate, and the size varies from a few millimeters to several centimeters. The clinical significance, of course, in RH isomerization patients, the presence of an intravillous thrombosis may actually lead to sensitization. So if it's a priming and you find and you're not in the habit of giving antenatal, there is prophylactic anti-D. If a patient has intravillous thrombosis, it may be better to give anti-D in the antenatal period. Then it has no association with PIH, smoking, small for gestational age, or ethnicity. So here are typical intravillous thrombosis, where you can see cystic areas there, and then usually they are surrounded by echogenic ring. They are quite multiple in number, and this can actually have a normal outcome. Okay, but the other thing we are concerned about in the placenta is the placental infarct. A small placental infarct is difficult to diagnose unless complicated by hemorrhage. Now there is a lack of blood supply in an area, and that area becomes infarcted. Over a period of time, the infarction actually liquefies and cystic areas result. It's seen in almost 25% of placenta and uncomplicated pregnancies, and most of the time these infarcts are diagnosed at histopathology of the placenta rather than in the on the ultrasound. Its placental infarcts are more common in the base of the placenta, and where there is a disruption of vascular supply, which results in necrosis of the villi. And small infarcts, as we said, have no significance because it's already occurring about 50%. So you can see these white areas can be considered as areas of infarct, but as I said again, you cannot use ultrasound to rule out placental infarct. So here a patient with intrauterine demise, you can see the placenta looks quite normal, and the cut section of the placenta looks quite normal, but on histopathology we find there is a massive inflammation of the villi, and this is called a condition called villitis of unknown etiology. The villitis of unknown etiology is an autosomal recessive condition, so that's why we can have some patients coming with recurrent IUDs, and if you do a placental histopathology, you will identify the reason for recurrent IUD in the patient. So a normal looking placenta, absolutely normal in thickness, the liquor is normal, everything looks fine, even the cut section of the placenta after delivery looks normal, but histopathology shows a problem. That means when all placentae must be examined in detail, when there is an adverse outcome, the placenta forms an integral part of the examination. Right. You can see the mononuclear infiltrates in the placenta. So villitis of unknown etiology is associated with recurrent abortions, IUGR, intrauterine demise, and the etiology is actually unknown, but there have been reports where recurrent pregnancy losses they have identified villitis of unknown etiology. So close monitoring and timely delivery is important. Now here is a 22 to 23 week figure where there is ascites, okay, and there is a prominent fistula magna, normal liquor, normal diameter. So whenever we see fetal ascites, what comes to our mind is could it be due to intrauterine infection? And when there is infection, it has to come through the placenta. So the placenta is one of the organs which could get also participate in the infection process. You could have a very large placenta and demise placenta, or sometimes even a normal looking placenta. So again, when you have the fetal ascites, you need to investigate some other. This mother was investigated. She had IgM CMV positive, and also the PCR was positive in the amniotic fluid. The baby had hyperbilirubinemia, and also increased enzymes. And when you look at HPE of the liver and placenta, there was inflammatory infiltrate, and the placenta HPE showed classical CMV infection. So again, one more reason why even apparently normal looking placenta must be examined under the microscope. Here's the case of non-immune hydrops, and when you have hydrops, and then we spoke about RHI segmentation, which is immune hydrops, which have a large placenta, and in non-immune hydrops, some types of non-immune hydrops, you can have a large placenta. And this patient who had a large placenta, we did the histopathology, and that histopathology actually gave us the diagnosis of a storage disorder. So this baby had Gaucher's disease with classical Gaucher's cells in the placenta. So for this mother, this was a conclusive proof that this baby had Gaucher's disease, an autosomal recessive condition, and we could do prenatal diagnosis in the next pregnancy at 12 weeks or so. So it's important again examining the placenta in a case of non-immune hydrops. Next we go to placenta previa, where the American College of Radiology appropriateness criteria recommends that the description of the relationship between the lowermost edge of the placenta and the internal cervical os. I think this is quite important. Whenever you do a scan, when you report on the placenta, you always say placenta anterior or posterior, but take care that the lower edge of the placenta and the internal os must be identified as two separate structures. Find out how close they are or how apart they are. And if it is less than 2 centimeters, the lower edge of the placenta is less than 2 centimeters from the internal os, then we call it as a low-lying placenta. But the whole issue is, if you look at the incidence of placenta previa in the second trimester, it's almost 5 to 30%, and when you go to the third trimester, it's only 0.6%. That means whatever you saw in the second trimester literally disappeared in the third trimester, and this is because of the phenomenon of tropotropism, and also the uterus is becoming bigger and bigger, and the placenta migrates upwards. So we can say for one that in early pregnancy, if you see in let's say second trimester, if you see a fundal placenta, this fundal placenta will never ever become a placenta previa. If you see a placenta at the lower segment, then it can potentially migrate to the upper segment. And so if you see a placenta which is completely covering the internal os in early pregnancy, let's say in the second trimester, then it's unlikely it will completely migrate upwards. So a fundal placenta will never become a placenta previa, and a complete previa in the second trimester is highly unlikely to migrate completely. May migrate partially, but the threat of placenta previa being there is always high. Now, when you're trying to assess for placental location, you can see a full bladder here, and over distended bladder can actually give you a false diagnosis of placenta previa. So we don't over distended bladder abdominally, and any suspicion of a low-lying placenta, you have to do a transvaginal ultrasound to identify the internal os and the placental the placental edge. So when placenta previa is diagnosed, you look for evidence of placenta accreta, growth abnormalities, congenital abnormalities, and also placenta previa. So that brings us to the question of an adherent placenta, which is actually an abnormal attachment of the placenta to the uterine wall, which results from the deficiency in the decidua basalis. Now, it's quite important to understand or identify adherent placenta activation, because the risk factors of previous cesarean section, the previous history of placenta previa, or even and there's a placenta previa now, and repeated dilatation and curettage which has happened to the patient. So here's a normal placenta, as you can see. Here is an accreta where you can see the invasion of the placenta into the myometrium, and then you have an increta where it's gone into the myometrium, and a percreta where it has gone to the serosa of the uterus. It's completely invaded out of the myometrium. Now with ultrasound, it may be difficult to differentiate between these, but when it is going completely invaded out of the myometrium, you probably will see irregularity of the myometrium. So here the normal placenta again with a good retroplacental space, so we can say there is no placental adherence here. And you look at the placenta, the question is when can you actually diagnose adherent placenta? In the first trimester, second trimester, or third trimester. In the first trimester, we can actually triage a patient and say in a case where there is a low implantation of the gestational sac, this patient has got a high risk of having a placenta, adherent placenta or placenta, especially in cases of previous infection. So, a patient with previous infection, early pregnancy, you see a low implantation sac. I am very worried about that patient. Now, second or third trimester, placenta previa and non-visualization of the reproductive space. You first identified by that, and then you can see diffuse or focal intraparenchymal lacunar flow. I'll show that in a minute. Now also periplacental and peripresence. Now here in the early pregnancy, you can see a very low implantation of the sac. This was the area of the scar, previous scar, and this patient will certainly be a high risk for having adherent placenta. So in the second or third trimester, here you can see some portion of the retroplacental space is seen, but as we go off the retroplacental space, we are actually getting obliterated. And these are the placental lucencies I showed you about. You can see that's the cervix, that's the bladder. You can see the myometrium is extremely thin. The head of the baby is here, and the placenta showing quite a lot of irregularity and a lot of cystic spaces. And you can see the retroplacental space is completely obliterated. And when you switch on color, you will see the color flow in a typical fashion, in a radiating fashion, going towards the placenta. Normally, the direction of flow of the retroplacental plexus or veins is along the uterine wall. Here you can see going perpendicular to the placenta, and that is a concern because this means that is engaging the myometrium. That's a normal flow which you can see here, and here you can see an adherent placenta again. Right. There is a priming spotting for venom at 8 weeks, and to lose our placenta previa, and here obviously you can see a complete placenta previa there. And the question at 24-25 weeks, we thought we could see some retroplacental space there, but you should take care that while doing ultrasound, this area is perpendicular to the ultrasound, and normally you can see a hypoechoic space there in all pregnancies. So that means your retroplacental space should actually be identified in the area. So the suspicion of an adherent placenta was made, and the placenta was asymmetric. At 32-33 weeks, you can see the space is obliterated now, and with transvaginal ultrasound, you can see an adherence of the placenta to the uterine wall. So luckily, this patient was found on time, and at delivery, they had to give almost like 8 bottles of blood. Sometimes when there's placental adherence, they deliver the baby and leave the placenta behind and manage it later on as it goes. Right. Now, what about abruption? Abruption of the placenta and an ultrasound diagnosis, if we are able to make a good diagnosis of abruption, it will be very good for the patient. Unfortunately, ultrasound is not as good for diagnosis of abruption of the placenta because a negative diagnosis, that is, you don't see anything, patient is bleeding, and you don't find any findings of ultrasound, you cannot exclude the abruption. But it can be suspected when you see a sonographic area between the placenta and the myometrium, and there's a rounding of the placental edge, the thick placenta. Of course, the differential diagnosis will be myometrium contraction, uterine fibroid, and placental tumors. Here, for example, is a placenta which had a large hemorrhage behind, and it turned out to be a large retroplacental hematoma. You can see that the entire area is what you're seeing here. Right. Then lastly, we have to look at placental tumors. Placental tumors, trophoblastic tumors, placenta with cystic spaces like your vesicular mole, which is classical, and non-trophoblastic tumors, scoriangioma, and a teratoma of the placenta. Now here the typical chorioangioma of the placenta. It's a tumor which is usually seen in the surface of the placenta and bulges into the amniotic cavity, or it could be the placental substance which is there. Usually chorioangiomas have very high vascularity, and because of high vascularity it behaves like an AV malformation, and you can see a large size hepatic vein, portal vein. The baby is having actually cardiac failure stage, right of the regurgitation, and a large chorioangioma seen here. So treatment is available for chorioangioma for some of these cases where you can do a laser and cut off the feeding vessels, or you can do intrauterine embolization of the chorioangioma. But as opposed that here's another chorioangioma which grew in size, is almost like 34-35 weeks, and there was no effect on the fetus. So the effect of chorioangioma on the baby would entirely depend on the amount of AV malformation or the net blood flow which happens within the chorioangioma. So some of these chorioangiomas can become avascular as you go with them. So a close monitoring is what would be required in these cases. Then there is a condition which we all know, which is called as placental mesenchymal dysplasia. Now, placental mesenchymal dysplasia is also known as mesenchymal stem villus hyperplasia. It's a very rare placental vascular anomaly, but as you see this picture, you can see a number of cystic spaces in the placenta. This could be easily be mistaken for a vesicular mode or a triploidy, but it mimics a partial mode, and usually it features a normal fetus. So you'll have a cystic space in the placenta, the fetus will be normal. There's a partial mode, then you will find that the baby may have some structural abnormalities or IUD, or it's a total vesicular mode which is separate from the placenta. You have a coexistent mode and fetus, then that could be two separate entities altogether. So if you have a placenta showing multiple cystic spaces here and the baby is normal, growing normally, think of placental mesenchymal dysplasia. So here you will see enlarged thickened placenta at about 50%, cystic with hypoechoic areas in about 80%, cysties or moth-eaten appearance, and dilated chorionic villus in about 16% or so. But generally, because the fetus is normal, they are not associated with chromosomal abnormalities. Most of them can have a good outcome. So, and it can also regress over a period of time. But as we said earlier, when there is a small baby and a large placenta, you should think of partial mode or triploidy, and even in triploidy you might be able to see some cystic spaces. Here the karyotype is shown 69 chromosomes, telling you it's triploidy. So I'll leave you with the few messages. Placenta is the fetal lung and the kidney. Autopsy evaluation of the sick neonate is incomplete without placental work. So doing a fetal autopsy without a placental examination is actually a job of the half done. So all fetuses must be accompanied by the placenta, because generally the placenta travels from the boat to the package, and even if the baby is normal, the placenta should still be examined and ensure that because, for example, nearly 30% of chorioangioma are only seen after the delivery. It may not be seen antenatal. You must examine the placenta whenever there is an unexplained insight in death, growth restriction, and also any unexplained morbidity, and also look at macroscopic lesions. So thank you for the patient listening. If there are any questions, I'll be happy to answer.